Uh, Hi everyone, welcome to another Wednesday VMR. I'm here with Prof. Rez. How's it
Hi,
going?
hi. How are you?
Good, good. I was just telling Prof. Rez that I feel like I'm about to lose my voice. So if I go silent, it's probably because the case has stunned me, but also it might just be because I'm losing my voice. But fear not, Prof. Rez is here. Um, And big shout out to Laura and Glenn for scribing and doing teaching points. And we're so excited that Yusuf is presenting a case. Do you want to say hi to everyone?
Hello, everyone. I'm Yusuf, and I'm really excited to present my first case here.
We're so excited to have you. Do you want to say like where you're joining us and tell us like one thing you'd like to do outside medicine?
Well, I'm a fifth year medical student from Egypt, and I like to play guitar, and I also like to read.
That's awesome. That's so exciting. I'm always impressed with people who play instruments. That's a very, very cool. Well, thank you so much for being here. Hope it's the first of many more. And if we can get the board up, we'll get started.
Okay, we have a 24-year-old male with abdominal pain, diarrhea, and vomiting, and I'll stop here.
Well, yeah, this is Yusuf's welcome to the podcast. Not podcast, the VMR. This is an interesting start to the case. And I think it's interesting for two reasons. One, this is a young patient, but two, don't have the tempo yet. And tempo is queen in formulating our thoughts. So we have to be a bit patient here, Charmaine. And I'll just share a very brief reflection. Oftentimes, diarrhea or even abdominal pain doesn't necessarily localize to the GI tract, meaning someone might have a systemic illness and have diarrhea as a bystander. Someone may have abdominal pain, but it doesn't localize to the lumen. But I think once you add all three of these findings together, the abdominal pain, the diarrhea, and the vomiting, you're making a stronger argument that you're dealing with some kind of gastrointestinal luminal pathology. Not to say this can be anything, but the point I'm trying to make is that these findings separated don't add much diagnostic momentum towards the lumen, but when you get the triad, it really prioritizes the lumen as a site of pathology. I'll leave it at that. Let's get some more information because I think we need much more to frame the problem and try to solve it.
Okay, so the abdominal pain started 2 months ago in the left lower quadrant and the epigastric region, radiating to the flanks, and the pain persistent even if he didn't eat anything all day. He had 30 bowel movements per day. The stool was loose and with visible blood and mucus, and it also persisted without eating. And he describes the vomiting as containing food particles at first, but then it turns green. He lost 40 kilograms in 2 months. He has no history, and I'll stop here.
Thank you so much, Yusuf. I missed the last part. So after the weight loss, what was the last part of the information?
Uh, he has no history of mouth ulcers or uveitis, but he has a history of low back pain and bilateral knee pain.
Got it. This is very, very interesting, and thank you so much, Yusuf, for bringing this case. So I think, as Prof. has mentioned, we were cluing into GI tract being involved. And I think we have more evidence to support that whatever the final diagnosis is, has to explain his GI symptoms. I am struck by the 30 bowel movements a day. That is a lot of bowel movements. And in terms of like the abdominal movement that started 2 months ago, we're dealing with something that is like more in the subacute to chronic nature of it. So oftentimes when I think of abdominal pain, I always want to think about my no misdiagnoses, which is, your vascular pathology, your itises, your perforation, your obstruction in a woman, and also ectopic pregnancy. I am less concerned for one of those being at play constantly. Sometimes, like, volvulus or some sort are episodic. But again, with him, I think we can just put that aside and kind of think about, in general, even though we're like left lower quadrant abdominal pain, um, especially in the population that I deal with, like abdominal pain is just so really, really, really hard to localize. Um, for me, like at my like practicing, especially with older population, is that it would be anomaly for someone to tell me they have a right upper quadrant tenderness and have actually acute cholecystitis, for example. It's always like a little bit more dull, it's always a little bit more generalized. So something that, I've started not putting as much emphasis on where the abdominal pain is and allow like more clinical clues to hone me in. In terms of the diarrhea itself, maybe I'll talk about the diarrhea and then I'll have the prophress layer on all the other symptoms. Oftentimes, like, I think about it like whether it's like an inflammatory or non-inflammatory. The tests that would be like the things that would be helpful, any signs of systemic inflammations like fever, sometimes like fecal white blood cells, like really helpful. If there's any like pus in the diarrhea, which I believe it was. Uh, okay. Or it's just like persists with fasting. So in kind of like the buckets, oftentimes like in the, for example, inflammatory buckets, we worry a lot about like, IBD. Here's a really, really good age for IBD. So like inflammatory bowel diseases, especially if there's any other systemic signs that clue us into maybe arthritis of some sort, inflammatory bowel disease is something to consider in this case. Invasive infections are another one that can do it. In the non-inflammatory bucket, oftentimes the osmotic ones is the one that they won't have any symptoms throughout the night. And so with that history really, really help prioritize like secretory diarrheas or like and then like you have your fatty diarrhea, which is like probably less likely, and then your functional, which is like your diagnosis of exclusion. But in him, I'm like really worried about it, like inflammatory form of a diarrhea, and that would be kind of what would be my focus to try to get more history and also with more information. Professor, what do you make of the rest of the symptoms?
Well, Sharmin, I really love what you did there because we're seeing a bunch of findings on the whiteboard, but you focused on the most important, and that was the first thing you said was 30 bowel movements a day. So I think as we're framing this patient's problem representation, front and center should be diarrhea. And and I agree with you. I think we gotta decide, are we dealing with inflammatory or not? And I'm sure as we get more data, we're going to make progress on that. And we now have the tempo. This seems to be a subacute, progressive process. And boy, 40 kilograms of weight loss in 2 months, that's unbelievable. Unbelievable. I don't really have much to say about the vomiting beyond like the green makes me think that there's bile. So it makes me think that what's happening is above the ligament of trites. But I'm not too concerned for an obstruction right now because we don't have abdominal distension and we just don't have, and we have like a 2 month course. But yeah, I think where we're going to invest most of our cognitive energy is on the diarrhea. Yes, there's low back pain, there's joint pains. We're not going to make a leap yet and say it must be this diagnosis. We're just going to take our time and we're going to try to elucidate the nature of this diarrhea and the test. And I'm already like Charmin reaching into the diagnostic armamentarium, which includes stuff like a CT scan of the abdomen and pelvis with contrast. It includes upper endoscopy, colonoscopy, and potentially some serologic studies. So I'm looking forward to getting more data from Yusuf.
Right. So he was hospitalized 1 year ago during his military training and diagnosed with perianal fistula. He has distended veins in his legs and grade 3 hemorrhoids. His family history don't have any history of autoimmune diseases. He's not taking any drugs. He's a smoker and he didn't have any surgeries before and he has no allergies. And I'll stop here.
Sharmin, I don't have too much to add besides saying like the fistula brings to mind Crohn's disease and maybe adds a little more support for inflammatory bowel disease. But yeah, I don't know. Do any other thoughts from your end?
No, I totally agree. I think that, and I think like the other thing that I'm tracking is just like kind of low back pain and bilateral knee pain that he's had. Whether that's like spondyloarthropathy of some sort. He's like 24, so it's a little less likely to have like, OA or other etiology, whether that's like inflammatory arthritis that we're dealing with. And this like perianal fistula also kind of like paints a picture that we should worry about, like as you mentioned, IBD, but not anchor on it. All right. Yusuf, tell us more.
Okay. I couldn't get the vitals and the physical examination because no one recorded them. So I go straight into the labs. The white blood count was 3.3, RBCs was 4.6, hemoglobin was 10.3, hematocrit was 33, MCV 71, MCH 22, MCHC was 30.9, platelet 41. And I think I'll stop here.
Prof Raz, I need more Prof Raz today. Go for
Okay.
it.
Yeah, well, thanks for your honesty on not including the physical exam because we don't have one. What we have here is like as we're framing this problem, we're saying subacute, progressive, potentially inflammatory diarrhea based on a description of the loose stools with a history of a perianal fistula and other symptoms of low back pain and what seems to be symmetric polyarthritis or at least polyarthralgia. And then the CBC, I think what's striking here, Charmine, is that all the cell counts are down. You can imagine in someone with diarrhea that they're going to have some malabsorption, regardless of the etiology, and that they're going to be iron deficient. And we see the MCV is 71. And a lot of patients with Crohn's have iron deficiency. They also have vitamin D deficiency. And so I was expecting to see the microcytic anemia. The thing that surprises me here is more so the thrombocytopenia and the leukopenia. Whenever you have three cell lines down, the odds are probably 95% that you're dealing with something related to the bone marrow. And when you're dealing with something related to the bone marrow, and just to back up just a slight bit, peripheral destruction is often one cell line or two cell lines, primarily the
Uh,
hemoglobin and the platelet.
sorry,
Um, the other way you can get
I'm sorry to
peripheral.
interrupt,
Oh, yes.
but I think that the platelet is 358, not 41.
Oh, okay. Well, that's really helpful. Thanks for interrupting. I mean, then that completely
Okay.
reframes this as maybe a slight leukopenia, but primarily an anemia. I think the next test I would do before putting too much thought into the leukopenia, the mild leukopenia, is I would get iron studies. Because what I'm most concerned for here is significant iron deficiency anemia. Um, yeah, and I would, for a patient like this, send the vitamin B12 studies including methylmalonic acid and homocysteine. And I would get a peripheral blood smear. But yeah, Charmin, I think right now everything is just, leading us towards the GI tract, towards inflammation, and towards Crohn's, to be honest. I have to be taken off this roller coaster or this car that's heading towards that diagnosis. But nothing so far is incompatible. And I would never prioritize the mild leukopenia over the significant diarrhea where I can just explain the anemia through iron deficiency. I would have to get the iron studies and it would have to be something unusual for me to then be like, oh, wait a minute, maybe it's something more that involves the marrow or peripheral destruction.
Oh, yeah, I 100% agree with you, Prof. Raz. I think it's hard, like, I think with this history and the perianal fistula, like, not that many, like, systemic diseases, none of the infections that I'm aware of that we often think about, like, those fistulization. So I think Crohn is a good bet in this case. And yeah, I totally agree in terms of, like, anemia and the leukopenia. B12 for like I think there's so much malnutrition and malabsorption happening. So I even with the pancytopenia, I don't think I would have been terribly surprised. And given kind of the lack of access to nutrition with like 30 bowel movement, 40 a kilogram weight loss, and also like kind of the inflammation can definitely do some damage to the bone marrow. Um, I think like yeah, as you mentioned, I think colonoscopy is gonna like endoscopy and not colonoscopy is like one of the earlier things that we want to do to rule it out. I think in terms of like if there's any other like infection, I think a lot of it will depends on his risk factors, but in kind of like a 25-year-old. HIV, TB, and like thinking about maybe CMV and EBV are the ones to kind of think about. And also like the last bucket of like malignancy, again, I think that is like way, way down. So yeah, that's kind of like where I am in this case. So yeah, back to you, Yusuf.
Okay, so his total bilirubin was 0.22, the direct was 0.13, AST was 7, ALT was the ESR is 57, CRP is 69, calprotectin was 937, and the CMV IgM was zero point 0.2, the E was 140,
Hey,
and I'll
Yusuf,
stop
I'm so
here.
sorry. I don't know if it's just me, but your keeps going in and out, so I didn't catch most of that. Would you mind just restarting?
Okay, did you got the bilirubin?
No, to be fair.
Okay, the bilirubin was 0.22, the direct was 0.13, AST was 7, ALT was 6, the ESR is 57, CRP is 69, uh, calprotectin was 937, the CMV IgM was zero point 0.2, and the IgG was 241.
Um, are we ready for some endoscopy and colonoscopy? Yeah, I feel like that is where we're leading. In terms of like, ESR, CRP being elevated, again, like markers of inflammation. And I think when we were thinking about like, oh, is this like an inflammatory diarrhea versus like a secretory non-inflammatory diarrhea? I think like the anal fistula kind of clues us in more to the inflammatory bucket being worried about Crohn's. And I think like calprotectin being positive, it's another clue that this patient should get an EGD colonoscopy. And in terms of CMV, like I think that IgM is like negative. Although to be honest with you, with EBV, especially like more than CMV, I always have to look up the and up to date about like what does the serological testing means. There are like so many different variation of it, but I think with like that calprotectin, I would want an endoscopy and colonoscopy to rule out Crohn's. Prof. Rest, anything else?
Nada. I think you are spot on, and I am with you, Charmaine.
All right, Yusuf, back to you.
Gastritis, esophageal candidiasis, and H. pylori
I'm
positive.
so sorry, friend. You might want to.
The colonoscopy was suggestive of TB or IBD. And the next, Alex,
Oh,
do
sorry,
you hear me
friend.
now?
Um, I'm having a hard time. I don't know if anybody else is. You might want to, one thing that might be helpful if you want to like turn off your video, sometimes that helps. And if you can like repeat it, that would be awesome. Repeat that like well.
Did we lose him, Charmaine?
I think we might have. Let me see. Yeah, let's give it like a little bit of time. I'm sure he's on his way of getting reconnected.
Yeah.
I'm sorry, everyone. The internet went off. I'm so sorry.
No worries at all. It happens. It
Do you
happens.
now?
Yeah, I can hear you now. Perfect.
Okay. So the upper GI endoscopy showed mild pangastritis and esophageal candidiasis, and it was H. pylori positive. The colonoscopy was suggestive of TB or IBD, and the next aliquot would reveal the diagnosis.
Yeah, Yusuf, thank you so much. Yeah, we heard you nice and clear. Um, that is interesting that this patient also has H. pylori, and I'm glad they did the upper endoscopy because H. pylori unchecked can lead to mucus-associated lymphoid tumor, which can be devastating if it stands long. The esophageal candidiasis is interesting. I think it goes back to what Charmin said that an HIV test would be in order. But let's talk about like the colonoscopy and Crohn's versus TB. I think to be able to understand why the pathologist is saying it can be one or the other, we have to understand what do we expect on biopsy for Crohn's and what is the illness script for Crohn's. And luckily, we actually have the illness script, and I'm going to pull it up here, and then we'll look at the um, one second actually. Let's start with the biopsy. That's fine. Here's the biopsy. You got, Sharma, you can see this Glass Health page, but here's basically the features just depend on the stage and location of the disease. But I think for everyone that's on this VMR, just remember these first two. Because if you remember the first two, then you understand the pathophysiology, and then you understand why people may, bring up TB in the differential diagnosis. The transmural inflammation is really important. It involves all the layer walls of the intestines. And why is that important? Because then you can understand how a sinus tract can develop and how a fistula can develop in Crohn's. It's transmural. The entire wall is inflamed. And then the pathology is really non-specific. It's this buzzword granulomas. And I think we all know that granulomas can occur in not only IBD, but a lot of infections from TB to fungal disease to lymphomas to autoimmune diseases. And TB for sure is a mimicker of inflammatory bowel disease. So you have to be pretty confident when you're making this diagnosis. And so then the question that Charmaine and I have to discuss is like, is this TB or is this IBD? Now you have to understand this. The pathologist is just looking at the scope at the sample. They don't have the history of the patient. So anyone who gets a biopsy of the GI tract that has Crohn's and it shows granulomas, it could be consistent with TB. But you may say, wait a minute, I read in the step one book that if it's caseating, it's TB. If it's non-caseating, it's IBD. If it's necrotizing, it's this. Those really don't pan out in real life, meaning that you can have a necrotizing form that's not TB, and you have a necrotizing form that is IBD. There is no 100% correlation between the type of granuloma and the end diagnosis. Charming, for me, I know the primary extrapulmonary site, or one of the primary extrapulmonary sites of tuberculosis and lymphoma can involve the GI tract, but we didn't really get much systemic inflammation. It's almost like the inflammation is just localized to the GI tract. And we didn't get any prior pulmonary nodule, any prior, history. There's a good chance, I would imagine, if Egypt is like you, that their latent tuberculosis affects 2 billion of the world population. So there's a good chance he has latent TB. But my instinct is to say this. Yeah, like we'll wait for the cultures. I think in an endemic area, it's fair to do the PCR and the AFB stain. But if the PCR is negative, the AFB stain is negative, and even if they're not, I mean, even if they're not done, I don't know what else would make me think TB over I like this is such a good fit for IBD. But we can all understand why it's such an important question because IBD treatment oftentimes now people are starting with TNF alpha inhibitors and strong biologics, which would, if someone had TB and you block TNF, which is controlling the TB, it's going to go rampaging through the body. So I'm curious to see how you're juggling the pathologist saying TB and then the clinical context that the patient's presenting with and what you're prioritizing.
And yeah, I totally agree with you. And I think like what you were saying about like kind of base rates affects kind of how we approach things. And I think in countries that TBI is more endemic is always like atypical presentation of TB tends to be more common and it should always be on the differential. The one thing that makes me um move away from TB is like kind of the perianal fistula. Like I've never heard of a case of TB causing like perianal fistula. So that to me makes IBD more likely. The one other thing, I was thinking about was like, oh, like kind of running those IBD mimickers, infections that we've talked about. The Candida makes me, I'm sure like if you have bad inflammatory disease, you can get Candida, esophagitis. I always like think about it in terms of like I always like invokes like immunodeficiency, and I know like common variable deficiency can cause like enteropathies and at times like I can mimic IBD. But again, like I don't think it causes perianal fistula. So the other way I was thinking about like, oh, is this patient immunosuppressed that is more prone to infections, like any type of infections? And you're seeing Candida, you're seeing H. pylori, and you're seeing a TB, which again, like I think we're invoking too many things. And again, that wouldn't explain the perianal fistula unless like he has trauma or anything else that would cause perianal fistulization or surgical that we haven't heard about. And I think if we were dealing with like a immunodeficiency, I would have assumed he would have like been shown up sooner than he was like 24. But I think like as you mentioned, like getting an HIV test is really important. I think the big question is like, do you delay treatment until you wait for the cultures to come back? Um, I think there's a degree of his symptoms. It makes me with talking to GI. I think like what I would do in real life, like review with pathology, make sure it's like caseating or non-caseating, or they can have anything, stain it, send it out. If possible, like do a PPD or quantiferon to make sure if he has latent TB, then no matter what treatment we will start him, he should get treated for latent TB because we're gonna immunosuppress him. But I wonder if this is a case that, otherwise, like healthy 24-year-old, you can proceed with treating the IBD. And usually, if it's TB, you get a poor response. But hopefully, it won't be the case. But I agree with you. I think like I would want to treat this person sooner than later, than like rather delay it for weeks. I think we can like start with the pred at least, and then add the TNF alpha ones like later on. It's kind of like how I'm approaching this case. Prof. Rez, any other thoughts?
No, I love the way you dissected that.
All
All
right,
right, so
so
the TB and HIV tests were negative, and the histopathology was suggestive of Crohn's, so the final diagnosis was Crohn's disease.
that's well, wow, that's a really, really good journey. I love it when we get to talk about inflammatory bowel disease and go to like have a typical presentation as well, just to hone our own skills and yourself. Thank you so much for presenting. Any learning that you wanted to share from this case?
Well, I think the importance of history, because once he said he had a history of perianal fistula, I I knew what to expect from the endoscopy and the colonoscopy.
Yeah, exactly. It's like one of those like specific finds, like perianal fistula, really, really narrows that differential. Versus like if you didn't have that perianal fistula, you can imagine that the deciding between the TB and IBD would be monumentally harder. Um, yeah. Any other thoughts, Prof. Rez, before we hand the mic to Glenn for teaching points? You're brilliant, Prof. Rez. Love discussing cases with you. Thank you for making the time. Thank you, Glenn. Mike to you.
Uh, Thank you, Sharmin and Reza, for the discussion. Learned a lot from the case, and thank you for Yusuf for presenting the case for the first time. Uh, so starting us off, for the first delegate to talk about abdominal pain, diarrhea, and vomiting. Um, so most likely suggested a GI problem. Then we localized it to the left lower quadrant. Thought of diverticulitis and IBD. Then for diarrhea, for the causes, we divided them into inflammatory, non-inflammatory causes, and also further divided them into secretory, functional, non-secretory as well. And here, wanted to know more of systemic features to further uh, rule out other causes. For the vomiting, it was didn't really help us with dissecting the case, but we were less concerned about obstruction, and it meant the problem is around the bile duct. For the fistula, I think this was a main turning point for the case. We strongly suspected Crohn's disease because of the transmural inflammation that it causes, and most likely can lead to fistula. And then for the back and knee pain, further on what we got from the review of systems, it meant it could be reactive arthritis or ankylosing spondylitis, considering the patient is 24 years. We also from the labs got the biocytopenia. So from here, we thought of iron deficiency, vitamin B12 deficiency from the malabsorptions. And then from other labs, we got the inflammatory markers were positive. So uh, we are certain that it's an inflammatory diarrhea. Then we wanted to know more of wanted the colonoscopy, endoscopy from there. Colonoscopy um, uh, wasn't sure whether it was TB or IBD. And then we had a little discussion there that the two main biopsy features for Crohn's disease will be the transmural inflammation, the non-casing granuloma. And because TB also causes granulomas, that can lead to a confusion between a TB and IBD. And for this patient, because symptoms were localized to the GIT, we thought more of IBD rather than TB. TB will affect other systems as well, and also it's not associated with fistula. So here we wanted to do more TB tests just to rule it out. For the candidiasis, we thought maybe patient could be immunocompromised and could explain other infections, the H. pylori, the fistula as well. And wanted to get the HIV test, which we got, and it was negative. So that will be all for my teaching points. Thank you, Yusuf, again for the
Uh, Thank you
and
so much, Glenn, for summarizing the teaching weight so greatly. Thank you. Really appreciate it. There was like a really great question in the chat about what we make of the esophagitis. Profess, do you want to just so that people on YouTube also get to
Yeah,
experience that?
well, I'm not a huge fan of the YouTube audience, but I'll still answer because I'm a fan of you, Sharni. You
For
know,
me.
it's so interesting. Like when we read our medical textbook, like we're taught that, oh, if shingles happens in a young person, it must mean that they're immunocompromised. Or if someone has esophageal candidiasis, it must mean but this word must mean doesn't exist in medicine. And once you practice long enough, you learn that there's so many variables that we've yet to understand. So in this patient, and I put this in GPT, they said, yeah, of course, it should make you worried for immunosuppression, but it can certainly happen without any immunosuppression if there are local factors or functional factors. You can imagine if someone's just vomiting a lot, they're not swallowing, then and stuff is just hanging out. That's like a good milieu for Canada to grow. Um, so I just think that we have to be cautious. So what do you do with this? What you do is, hey, if I say esophageal candidiasis, I'm not going to dismiss and say the immune system is intact. I'm going to check for it. Even if it's intact, it's still fair game. And maybe I'll think about functional and local stuff. If a young person has shingles, that's odd, but it definitely happens. I'll still send the HIV test. If it's negative, that's okay. Like it's not a lunar eclipse. I don't know how common a lunar eclipse is, but I've been using that phrase a lot recently. I should look into the frequency of a lunar eclipse to make sure it's right.
Yeah, brilliant, brilliant, Prof. Rez. I 100% agree. Most patients and situations don't read our textbooks, although this patient did in terms of the IBD, so I appreciate that. But he did not in terms of the esophageal candidiasis. And Mark actually made this point in the chat as well that I wonder if it like is severe like malnutrition. I know like it can cause like some lymphocytic dysfunction, impaired mucosal immunity. Curious to see what his albumin is. So like malnutrition can do a lot of badness to the body and really does affect your immune system. So I wonder that also could put this patient at risk of candidiasis. I just want to keep nerding out with you, Prof. Rao, so I'm just dragging this. All right, everyone. Thank you so much for joining us. Yusuf, really appreciate you for presenting a case. Please come back. Loved it. Have a good day, everyone. Thanks for joining us. We'll see you tomorrow.
Bye,
Bye.
Charmaine.
Bye, y'all.